Let me welcome Martin Roland. I'm very happy that you are able to come, Martin. Martin Roland is a professor of health services research in Cambridge and is also a part-time GP. We are going to hear about whether money is the answer to improving quality in primary care, which is a burning question all over Europe, and UK has some very good experiences in that. So thank you very much, Martin.
Tina, thank you very much. Thank you for asking me. So Freda has given us an introduction which has been quite general, and I'm going to be very specific. And so you're going to have to concentrate. I'm going to talk about the experience of the UK in quality incentives, financial incentives to GPs for providing high quality care, the so-called Quality and Outcomes Framework. And it is, I think, of interest to all our countries as an example, partly because it is a very large scheme and partly because it's been going for quite a long time. So we have a scheme which has now been in operation for 7 or 8 years. A quarter of GPs' income is dependent on the quality of care that they provide, so there's a large amount of money being put into it, though not necessarily a large amount per indicator compared to some other schemes. There are just a lot of indicators. Now, those of you who are hoping for a simple message from this talk may be disappointed, because the message is unfortunately a complicated one. So I don't know what you see when you look at this picture. Do you see a beautiful lady? Do you see a beautiful lady who is being formed from different parts? Or do you perhaps see a beautiful lady who was once beautiful and is now disintegrating into different parts? So I think the message that I have to give is not a simple one, it's a nuanced one, and you will see shades of this, and of course you will see shades again tomorrow when I and Heath and Jose Braspinning have a debate around the value of performance-related pay. So just very briefly to tell you about what the structure of the incentive scheme is in the UK, so you know the background to what I'm talking about. The incentives cover a large number of conditions. They started off with a smaller number, and the number of conditions has increased gradually. Within those, of course, what is measured is what is measurable. And one of the features of any pay-for-performance scheme is that you reward things that can be measured and tend not to reward things that can't be measured. And that's a very important feature. Here are just 2 examples so you get an idea of what the scheme looks like. There are 2 indicators on this slide. The first is the percentage of patients with coronary heart disease whose notes have a record of cholesterol in the previous 15 months. And GPs score 1 point if they manage that for 25% of their patients, and a sliding scale up to 7 points if they manage that for 90% of their patients. The second indicator here is not a process measure like the first, it's an intermediate outcome. And that's the percentage of patients with coronary heart disease whose last cholesterol is 5 millimoles per litre or less. Here the GP again gets 1 point if they manage that for 25% of their patients, up to 16 points if they manage that for 60% of their patients. So this is a more difficult indicator. There are more points and the top threshold is lower. These thresholds, however, have been increasing steadily year on year. And points translate into pounds. All the data are collected automatically from electronic GP records. GPs were already extensively computerized in the UK before the scheme came in 2003-04, but then at that time, they all completed the process of computerization because without electronic medical records, they couldn't be paid. This means that diagnoses have to be coded by the GPs, and data on the computer drives the payment. Information on quality of care is publicly available. So, for example, on this slide, which is my own practice in Cambridge, that's where we are, if anybody wants to come and see me, you can see what our score is on these indicators for coronary heart disease, people with a blood pressure measurement, how well the blood pressure is controlled, cholesterol measurement, etc. So you can go and look this up for every practice in England, as indeed you can look up the results for all questions on a national patient survey that is carried out across England. Indicators or guidelines were never intended to apply to all the patients we see in our surgeries. And so GPs are given the ability to exclude patients from these indicators for a range of reasons, because the patient refused or the GP just decided that it was not clinically appropriate for that question. Government, of the whole time that the Quality and Outcomes Framework has been in place, have hated exception reporting because they believe that it is a license for GPs to cheat. GPs, on the other hand, believe that it is an essential part of getting buy-in from clinicians and avoiding a scheme where they would be potentially giving treatments to patients who they believed should not receive those treatments. Okay, that's a brief outline of the scheme then. So first, what has the effect been on practice organization? Well, self-evidently there was increased computerization. Teams have become larger, especially with more nurses, also with more administrators. But GPs in England, who already work mostly in small groups, have seen the way to improve this type of chronic disease management, which can be largely protocol-driven, by employing more nurses in their practices. So much of the routine care, for example, for patients with diabetes, the annual diabetic check, would now in the UK be done by nurses. So we have developed an increased number of nurses with a greatly increased range of skills. Because the way the payment system in the UK works is the payment goes to the practice, which is usually owned by a GP, but not always, and it is up to the practice to decide who delivers the care. So you can deliver the care with 10 doctors and 1 nurse, or 10 nurses and 1 doctor, providing the care is delivered to the standard required. Now, my second question then is, what has the impact been on clinical care? And this, I guess, is perhaps the most important question, and I'm going to spend some time on it, and I'm going to describe 4 different research studies that have been done by my group in Manchester to answer this question. But first of all is just to show you, in the first year of the scheme, this is the distribution of points achieved by practices in England. There was a maximum of 1,050 points, and you can see that most practices scored the maximum. This caused the government some embarrassment because the red line shows the estimate that the government had for the first year of the scheme. So there was a gap of £400 million, which was unbudgeted. But maybe this care was already good. Maybe the financial incentives had nothing to do with this at all. So we did a study, and this is the first one I'm going to describe, where we measured quality of care in great detail in 42 practices scattered around England that were nationally representative in terms of size, deprivation, and other things. We had already been and done this work in 1998, and when we could see that the scheme was arriving, we went back in 2003, 2005, and 2007 and measured care again. And this is what we found. So, along the horizontal axis are the years, and quality scores are on the vertical axis. These are quality scores from a set of indicators that we developed in the mid-1990s and went into practices to extract data either from paper records in those days or subsequently from electronic records. So if we take coronary heart disease first, which is the red line, what you can see here is that care was already improving rapidly, and it just carried on and then plateaued. A slightly different picture for the green line and the yellow line, which are asthma and diabetes, where you can see that care was already improving before the QOF, but at a slower rate, and there was an increase in the rate of improvement followed by plateauing. So, what do we conclude from this? First of all, it is very clear that something was happening in the UK already. And the answer is that many things were happening. There had been a whole series of quality improvement initiatives, national guidelines, national standards, a lot of audit in geographical areas, with sometimes the audit being published usually to the doctors, occasionally to patients, some starts of financial incentive schemes, annual appraisal of all doctors working in the NHS. So a lot of things were already happening. And I think what you can see from this slide is, and it's consistent with other data, is the pay-for-performance scheme produced an increase in the rate of improvement, but it was not dramatic. And if you look at the literature on quality improvement, what things improve quality, I think a summary of that would be there's no magic bullet. There's no one thing that improves quality. And this slide is entirely consistent with that, and our experience in the UK is entirely consistent too. Pay for performance is not a magic bullet, but it is a potentially useful adjunct to other quality improvement measures. But what was going on here? Why did the improvement plateau? Well, there are two likely explanations for that. The first is the doctors had got their maximum points. So there was no financial benefit in doing any better. But the other thing is that for quite a lot of the indicators, the quality scores were potentially getting as high as they could perhaps possibly get. So for quite a lot of indicators, they were well over 90%. And if the message of that previous slide is that the quality indicators only had a small effect when given financial incentives, I don't want that to detract from the fact that over the period of time, there were very major changes and improvements in quality. So this slide just shows just two indicators from the previous slide, and I've chosen two for patients with coronary heart disease that are likely to be related to outcome. So the percentage of patients with coronary heart disease with controlled blood pressure went up from 48% in 1998 to 83% 9 years later, and the percentage of patients with controlled cholesterol up from 17% to 80% 9 years later. These, if you'll accept that these practices are representative of practices across the country, these are very, very major improvements to occur across a healthcare system. And I'm certainly not claiming that pay for performance is the answer, but the raft of changes that had been brought in, along with accumulating evidence of the benefits of treating high cholesterol, for example, clearly had had a major effect.